Ladies and gentlemen, it's the time you've all been waiting for, the start of Obesity Week, where this year's theme spotlights diabetes. Please welcome to the stage the presidents of the Obesity Society and the American Society for Metabolic and Bariatric Surgery, Steve Heimsfield and Eric DeMaria.
Thank you very much. Welcome to the Obesity Week opening session, our first keynote speaker. This year's theme is obesity and diabetes, and our keynote speaker is well aligned for that topic, Dr. Will Cefalu, and we'll present a little bit more about Dr. Cefalu later. The Obesity Week is a unique opportunity to get together not only scientists, but clinicians, bariatric surgeons, exhibitors, and people from industry to work together to solve this major problem, obesity as a disease. One of the unique features about this year's meeting is the extraordinary attendance. We have over 5,800 registered guests. This is the largest Obesity Week in history, the 7th in our series working together. And we have over 1,000 international attendees from 70 countries, major representation. This has become not only a national meeting, but an international meeting as well. And the exhibitors are also, if you went to the opening reception last night, there were over 140 exhibiting companies. Wonderful exhibit area, and I hope you'll continue to go there today. Throughout the week, we're going to have many sessions for both TOS and ASMBS. These are some of the highlights, and you'll see more about these as we move forward. We have 4 keynotes this year, and this is the first one. Dr. Will Cefalu will present his work in diabetes. Dr. Walter Porres will present ASMBS keynote, integrated health management. Dr. Phil Schauer will present the Mason lecture for ASMBS. And finally, Dr. Barbara Corky will present the TOS keynote later in the week. Very important to continue to participate in the exhibit area. The exhibit area has not only free coffee and lunch, which is a value, of course, but also you'll be able to see the poster sessions, the e-posters from ASMBS, the ASMBS Grand Rounds, which is a new feature, and also during lunch you'll be able to go to various topical areas. You'll see signs on the tables with areas that you might be interested in, and please join in. You'll find these of great value, not only the science, but the collegial relations you can build there. Also, the Obesity Week app is novel in many respects. It's interactive. You can, of course, put your schedule in there. You'll find various maps and exhibitor information, but also you can get your CME credits through that by signing in with your badge, and then that'll allow you to rate the different sessions and also collect your CME credits. Now, we're going to turn the session over to Dr. DeMaria.
Okay. Thank you, Steve. It's my privilege to thank the hardworking people that have created this year's Obesity Week meeting. As you can imagine, this is a huge undertaking, but the results of the tremendous efforts of both ASMBS and TOS members is what I hope you'll agree is a truly outstanding program. On this slide, we have the program chairs from both societies, and I'd like to recognize them and appreciate them for all their hard work. They've worked tirelessly to bring you a program that is filled with internationally renowned speakers on the cutting edge of obesity science, advances of clinical management of obesity, and obesity public policy. At this time, we'd also like to thank the TOS and ASMBS executive councils, the executive leadership of each society for all their hard work in bringing you this program, and they provide the vision and strategic guidance for our annual meeting. In terms of program highlights, all of the programming for this year's conference is clearly exceptional, but I want to point out just a few of the many highlights this year. When it comes to ASMBS's annual meeting, we feature a record 170 abstract presentations, including a new thing, which is the Distinguished Presidential Grand Round Abstracts, where past presidents of the Society will moderate alongside current bariatric fellows in training. New video presentations will also take place alongside this year's e-posters. In the TOS annual meeting, there are many collaborative symposia with leading obesity organizations on the program this year. You may notice there are sub-tracks dedicated to diabetes, pediatrics, and obesity medicine exam prep. Look for the track codes on signs and in the pocket guide, or filter the app program by track to see all the offerings. Don't forget to stop by the TOS poster sessions at lunch, where you can talk to the presenters of more than 750 research posters over the course of 3 days. Can I get a big round of applause for the incredible scientific and educational programs these committees have put together? I know they appreciate your appreciation for the work they've done. The success of our meeting is also dependent on the support and involvement of our industry partners. We would like to thank these partners for their sponsorship and educational grant support. Will you also join me in a round of applause to thank them? See, everybody's getting their exercise this morning. Everybody has to do some hand clapping. Now, we'd like to take a moment to honor two exceptionally dedicated individuals who founded and developed ObesityWeek, Gary Foster and Phil Schauer. As a tribute to their hard work and perseverance, the councils of both societies created the Foster-Schauer Travel Grant to bring early career investigators or international professionals to our meeting each year in the spirit of our shared mission to improve the lives of patients with obesity. Each recipient receives $2,500 as a travel grant. It's my privilege to announce first the ASMBS recipient, and then Dr. Heimsfeld will announce the TOS recipient that have been selected by the respective program committees from ASMBS and TOS. First, the ASMBS recipient, Dr. David Romero Funes, for metabolic surgery prevents systolic heart failure and reduces mortality due to recurrent MI in patients with a history of coronary artery disease, a nationwide case control analysis. Dr. Funes, please join us.
Thank you, Eric. And the TOS recipient, Anna Kamatska, is awarded for impact of biliopancreatic limb length in Roux-en-Y gastric bypass on glucose metabolism. Anna? Well deserved. It's now my privilege to present our TOS ASMBS keynote speaker, Dr. Will Cefalu. Dr. Cefalu is currently the director of the Division of Diabetes, Endocrine, and Metabolism at NIDDK. He has a long, distinguished career, more than 35 years in the area of diabetes and obesity. Prior to the NIH, he was the Chief Scientific, Medical, and Mission Officer of the American Diabetes Association, and before that, he was my colleague at Pennington Biomedical Research Center, where he was the executive director for a number of years, and he was the George Bray Jr. Super Chair in obesity. Dr. Cefalu has extremely a long history in the area of both diabetes and obesity, and he was the editor of Diabetes Care, the clinical research journal of the American Diabetes Association, and he was also associate editor of Diabetes, their basic science journal. It's my great privilege to present Dr. Cefalu for this keynote lecture. Dr. Cefalu, please come up. Okay. Good luck. I hope you can see.
Well, thank you very much. It's a real pleasure to be here today to be asked to give the keynote at the Obesity Week. I've titled my talk, Type 2 Diabetes and Obesity, Challenges and Opportunities, What Does the Future Hold? I have no conflicts to be reported. What I'd like to do over the next 45 minutes to an hour is to share my perspective on what needs to be done. We'll talk about the burden. We'll talk about as far as addressing prevention, remission, and then talk a little bit about precision medicine. Throughout the theme, however, I want to talk about, throughout the lecture, I'd like to talk about an evolving theme, the heterogeneity of disease, which is going to be vitally important, and I want to share with you at least some concepts today. When we talk about the burden, there's no question there's a problem in this country. 33.3 million with diabetes, 84.1 million with prediabetes. And for all of us know today, we do know that obesity is the main driver of conversion from prediabetes to diabetes. However, this is a global problem. When we talk about diabetes in the world, there are more individuals in the world with diabetes than the entire population of the United States. And this is projected to increase, a 48% increase by the year 2045 to 629 million. Now, the problem with this increase is going to be the complications. Not only the microvascular complications, the eye, kidney, and nerve disease, but we're learning a lot about diabetes this past few years as far as cardiovascular mortality and cardiovascular event and heart failure. So this mortality, this morbidity from the global population in the world makes this one of the most expensive diseases, not only in the world, but in the United States. I'd like to take a moment to put this in perspective. We know that currently in the United States, diabetes contributes, on the average, to a stroke every 2 minutes. It contributes to ischemic heart disease every 80 seconds. It contributes to kidney disease every 10 minutes, and an amputation every 5 minutes. Well, putting this in context, let's compare it to what we know an urgent crisis, and that's the opioid epidemic. And there's no question the opioid epidemic is a crisis in this country, with someone dying every 52 minutes from an overdose of an opioid. But yet, when you look at the statistics of diabetes, they're pretty sobering, and we can argue that someone dies every 2 minutes in this country with diabetes. Yet, I don't have to preach to the choir here of the urgency for treating obesity, or for that matter, urging in treating obesity in the face of diabetes. Now, based on this, we know that this is an expensive disease. Every 5 years, the American Diabetes Association puts its economic report out. The last one in 2017 reported last year. $327 billion was spent in 2017 on diagnosed diabetes, $237 billion on direct medical costs. Direct medical costs, a 26% increase in only 5 years, more than 300 million workdays lost to the economy, and 277,000 premature deaths. When we look at medication, medications to treat diabetes increased by 45% over 5 years, over half with insulin. The estimates, 1 out of every 4 healthcare dollars spent for the care of people with diabetes, 1 out of every 7 that was directly attributed to the care of diabetes. So we do know this: the current trends are simply not sustainable. So how do we even begin to address this epidemic and this global burden? Well, first and foremost, we take the challenges that we have today and we make them opportunities and put these into practice. And we've known a lot about prevention. We're going to talk about remission today. The future of precision medicine and individualizing care. These are all challenges, but yet opportunities. And what I think we need to address is an appreciation that type 2 diabetes is a collection of many diseases, and one size does not fit all. So let's take the natural history of diabetes. And we've seen this for years, that going from a pre-diabetic phase to a diabetic phase, you go through various stages. We know, however, that diabetes is a relationship between sensitivity of insulin in the peripheral tissues and insulin response. We also recognize that with obesity, there's a metabolic stress, ectopic lipids, inflammation, and you can call this pre-diabetic stage pre-diabetes, cardiometabolic syndrome, meta-obesity. It really doesn't matter. We know there's a stage of increased metabolic stress, and at this stage, a person develops insulin resistance. And then the pancreas begins to compensate to overcome that insulin resistance. And at this stage, the glucose is maybe at or near the normal level, and only when the pancreas fails to a certain point do the blood glucose raise into the diabetic level, and that is when we make the diagnosis of type 2 diabetes. But here is where one size does not fit all. We've seen this for years, but yet there's a huge variation, and I'm going to introduce the concept. Let's start thinking about the heterogeneity of disease. Because even this pancreatic decline, this insulin secretory decline, varies. Tremendous variability not only in adults, but in youth and adolescents and adults. So I want to work toward the understanding that maybe we should consider diabetes multiple subtypes, and we'll talk about that at the end. Let's first talk about the children. From the search study, we know that when we look at type 1 diabetes or type 2, the prevalence increased about 21% in 9 years for type 1, about 30.5%, even lower prevalence of type 2, but still increased about 30% in the 9 years of this observation. Now, what's really striking is when we see the disparities in adults, we see the difference in prevalence of diabetes and obesity in certain ethnic groups. Surprisingly, we're seeing this in youth, both for type 1 and type 2. Looking at the data, again, from the studies, looking at the incidence on the left of type 1 diabetes, the incidence of diabetes on the right based on ethnic groups, we can see that compared to the cohort, non-Hispanic whites have the greatest incidence of type 1 diabetes. In this study, the lowest incidence of type 2 diabetes. When we look at the other ethnic groups for type 2, we look at the tremendous increase of the American Indian, the non-Hispanic Black, and the Hispanic. So there's tremendous heterogeneity, not only in type 2, in youth and adolescents and adults, but within type 2 in youth and within diabetes among youth and adolescents. So we can argue that based on the proportion that primarily type 1 diabetes, arguably, is a disease of non-Hispanic whites. But then you look at the American Indian, Alaska Native, predominantly type 2, and the other ethnic groups about 30%. Based on the current incidence rates and the proportion, it is proposed that by 2050, we'll have 4 times the number of youth with diabetes as we have today. And you're going to see this is a problem because we don't have effective treatments for type 2 diabetes in youth and adolescents. So looking at treatment, this is a study, the Today study, that looked at treatment failure and treatment response with adult management strategies in youth and adolescents with type 2. Looking at interventions consistent of metformin, or metformin and rosiglitazone, or at that time metformin and lifestyle. You see the tremendous failure rates among all these treatment strategies. Now, if you look on the right, the non-Hispanic Black, the observation is perhaps they fail at a greater rate. So this suggests that the management strategies we use for youth and adolescents, for adults for youth and adolescents, they don't do as well. So this is a different disease. Type 2 diabetes in youth is a different disease. It's a more aggressive disease. It's less responsive to metformin and medication. Beta cell function declines considerably, lower insulin sensitivity, hyperresponsive beta cells, and reduced insulin clearance. So you look at type 2, you look at what's happening in youth and adolescents, and these are some pretty dire facts. Now, does that apply to the rest of diabetes and what we've done? And the answer is no. In fact, we've actually done a pretty good job with all the new advances in therapies, the new advances in management therapies and therapeutics, that since 1990, we've actually done a pretty good job reducing the rates of progression of heart disease and kidney disease and microvascular complications. We know that since 2007, there seems to be about 0.58% annualized rate of diabetes death around the globe. This is great news. Unfortunately, the United States is still in the top 5 for death due to diabetes, so we have a lot of work ahead of us. But the most promising thing that we see on the horizon in the recent past is the new drugs that have come on board. Since metformin in the 1990s, we've had the alkyl glucosidase inhibitors, the new insulin formulation, the TZDs, the receptor agonists, the DP4 inhibitors, the SGLT2 inhibitors. And it's been pretty impressive as to how many new drugs have come on the market and how it's changed the paradigm of treatment for type 2 diabetes. Now, you look at these new drugs and you go, well, yes, that's what's impressive about the advances. But there have been some other advances that perhaps have flown underneath the radar. And one we're going to talk about is the management strategies of metabolic surgery, which the data for diabetes was presented in Diabetes Care just a few years ago. We'll talk about that more in detail. There's a new consensus report on nutritional therapy for prediabetes and diabetes. And the reason this is important, one of the main questions people with diabetes ask is, what can I eat? And this is a consensus report that took experts in low-carb, vegan, vegetarian, Mediterranean DASH, and really looked at across the board what worked. Well, what came out of this, everyone in this room probably knows. There's no one diet that's best. The diet that works for the person with diabetes, the diet that's best for the person with diabetes, is the diet that works for the person with diabetes. Now, that may not be earth-shattering, but those are the facts, and there is no such thing as a diabetic diet, and if anything, this consensus report discussed that. The other management strategy that flew beneath the radar was the change from the ADA and ESD treatment approach to individuals with diabetes, coming up with a decision cycle where you make patient assessment first. You discuss with the patient. By step 5 is only when you begin to treat the patient. But the important thing here, in this decision cycle, the patient at the center of care, with the goal of not only improving metabolic factors to reduce complications, but for the first time ever in guidelines, a primary aim to optimize quality of life. So what this means is there may be situations where you have less aggressive control in management for diabetes, if that means less hypoglycemia and improving the quality of life for that individual. So these are some examples of what's happened across the scope of diabetes that have allowed us to continue to treat diabetes in the best way possible. So I think the biggest change in diabetes is what we learn about heart disease. We've learned from years that heart disease at least doubles the risk of atherosclerosis. And yet, at this point, we know that from 1998 to 2014, regardless whether you treated type 1 or type 2, there was a marked reduction in mortality and the incidence of cardiovascular complications between type 1 and type 2 and the general population. But the reality remains that there's still a substantial excess risk between an individual with diabetes, be it type 1 or type 2, and the general population with the current treatment strategies we have today. And we refer to that as residual risk. So this is why now it's of interest that when we look at these advances in therapy over the last 20 years, two classes in particular have effects beyond A1C, have effects on cardioprotection, reduced rate, reduced cardiovascular risk factors, renal protection, and reduced mortality. And because of these factors, they are now used a little higher in the treatment algorithm for many societies. What we do know is that no one could have anticipated 10 years ago when the FDA mandated cardiovascular safety trials that we would be sitting here today with positive studies from agents and changing the treatment paradigm for type 2 diabetes. But yet that's indeed what happened. Starting with insulin studies in Glargine and the Origin trial, which suggested that insulin may not be cardiovascular adverse. Continuing with the DPP-4 studies, DPP-4 inhibitors reduce glucose moderately. They're weight neutral, and for the most part across the class, cardiovascular safe. Then we have the receptor agonist, which pretty robust effects on A1C, reducing weight, and yet these have shown reduction in mortality, reduction in cardiovascular event. And then we have the SGLT2 inhibitors, reduction in mortality, reduction in cardiovascular event, significant reduction in weight. So the results from these cardiovascular trials really have changed the way we suggest therapy to those with diabetes. The meta-analysis, when we look at the receptor agonists, across the board about a 10% relative risk reduction in 3-point MACE, and about a 12% relative risk reduction in mortality in individuals with diabetes. And compare that with the SGLT inhibitors, about a 10% reduction. But again, the SGLT2 inhibitors have shown some effects on heart failure and renal protection. What this means in the grand scope of things, and this started a couple of years ago, when we suggest therapy to those with diabetes and we look at glucose-lowering strategies, one of the first things a provider needs to assess: is there atherosclerotic disease? Is there heart failure? Is there chronic kidney disease? And if so, perhaps determine whether atherosclerotic disease predominates, heart failure, chronic kidney disease predominates, and choose one of two agents in the two classes that have shown they have that benefit. Now, if there's no heart disease or chronic kidney failure, then you have at your disposal all the particular agents. And then you make a decision then. Do I want to go down a path that's going to limit hypoglycemia in that patient? Do I want to go to a path where what's important to that patient is the weight? Unfortunately, in some areas, we still have costs to consider. But the important point is that now you have choices of agents to make based on the patient preference and based on the underlying comorbidity. And these changes will continue, and you'll see even further refinement in these strategies moving forward. Now let's talk about metabolic surgery. About 3 years ago, I was honored to participate in the Diabetes Surgery Summit that Francesco Rubino and Phil Schauer, David Cummins, among others, put together. And the new guidelines were published in diabetes care and endorsed by over 45, I think more than that now, as far as professional societies. And this was important for the individual for diabetes because it showed conclusively that metabolic surgery compared to medicine and lifestyle was superior in improving glycemic control in those individuals with type 2 diabetes. And when you look at the individual data, it's pretty impressive. Here's the A1C before the metabolic surgery and the A1C after the metabolic surgery. We will talk about whether this meets the criteria for remission in just a moment, but pretty robust and profound decreases in hemoglobin A1C. The other important point to make is that metabolic surgery works, and you know this, and BMI is not an independent predictor. It works below a BMI of 45 as well as above a BMI of 35. So the guidelines changed for us in diabetes. We this new guidelines in diabetes care in 2016, and it continues today. And just summing this up, yes, if you have obesity or BMI greater than 35 and poorly controlled, recommend metabolic surgery. And we're not suggesting that anybody who has a BMI less than 35 consider metabolic surgery if they're doing well. But really the change comes in when you have a BMI less than 35 and you're responding poorly to pharmacologic therapy. Consider metabolic surgery. You may know this, but I think this is a huge change for our providers and for endocrinologists. And again, this data is not that old, and the guideline's not that old, just 3 years ago, and it's continuing to provide new information. All right, now for any intervention, what we'd love to see is reduction in complications. And for metabolic surgery, there's a lot of evidence now. This is from the Swedish obesity subjects. To the left, looking at composite microvascular complications. And over the 20 years, there's no question, reduction in eye, kidney, and nerve disease. To the right is macrovascular complications. And once again, a significant reduction with the Swedish obesity subjects. Now, we do not have randomized placebo-controlled trials for macrovascular outcome in metabolic surgery. So we rely on observational retrospective registry studies. This is a study that presented just last year and suggested, yes, a reduction from surgery from microvascular complications and a 24% lower risk with macro, but was not felt to be significant. But others, like Fisher's study and JAMA last year, saw a reduction in mortality, or the recent data from the Cleveland Clinic. And the recent data from the Cleveland Clinic used a 6-point MACE. Not only mortality, coronary heart disease, cerebral vascular disease, but other cardiovascular events that you see in diabetes, heart failure, nephropathy, atrial fibrillation. And as you can see to the left, a significant favoring of metabolic surgery for the 6-point MACE. On the right, MI, ischemic stroke mortality, significantly favoring metabolic surgery. Coronary artery disease, cerebral vascular disease events, significantly favoring metabolic surgery in this study. And all-cause mortality and heart failure, significantly favoring, in this analysis, metabolic surgery. So the data, what we have, there's always limitations to retrospective observational registry studies, but the data we have appears to be pretty compelling about the reduction in complications over time with metabolic surgery, clearly in microvascular, but the accumulating evidence now in macrovascular complications. So let's turn to the next. So now we have the management strategies that we know have worked. We've talked about heterogeneity, at least between youth and adolescents. Now let's talk about prevention. The Endocrine released a scientific statement a few years ago with quoting that control of obesity is the most important public health strategy for the prevention of diabetes and its complications. And to prevent diabetes, to overcome obesity, we know that now there are prevention studies dating back 30 years, starting with the Chinese study, the Finnish study, the diabetes prevention program, which looked at one of their arms, lifestyle, to reduce obesity. Then we have prevention studies that have looked at medication to improve resistance. Well, many of these prevention studies were short-term. They did show almost to the study that they were able to delay, not prevent, delay the onset of diabetes. By delaying the onset of diabetes, you delay the chance to develop the complications later. So we would say these are prevention, but they really delay, and again, you can see the risk reduction in these particular studies. Now, let's look at the diabetes prevention. Diabetes prevention, again, after 2.8 years, a lifestyle versus metformin and placebo, a significant reduction. but this proceeded through the observational period over 10 to 15 years. The data, after 2.8 years, 58% versus 31%. After 10 years, 34 and 18%, and this is where it was shown to be at least cost-effective for lifestyle and perhaps cost-saving for metformin. And after 15 years, 27% and 18% still affects 15 years later. Now, the question always arises, well, what does prevention do to complications? And we have to appreciate that diabetes complications takes a long time to develop. Individuals with A1C of 7, 7.5, 8% will take years to develop retinopathy, nephropathy. So when we talk about prevention studies with much lower A1C, it's expected that it's going to take longer term to see the differences in complications. So we have, after 15 years, some evidence from the diabetes prevention trial on complications and the Chinese study, which started in the early 80s. When you look at the complications today, the 30-year data has been presented, along with the follow-up of the 20 and the 23-year, that you looked at the upper right, still a reduction in diabetes incidence from that intervention 30 years ago. And then you look at cardiovascular events, and what I want you to appreciate is look where cardiovascular events begin to digress among the treatment groups, not until 12 years. Composite microvascular endpoints, once again, 10 to 12 to 13 years before you start seeing this divergence. And as far as reduction in deaths, mortality, difference in 30 years, but once again, you're seeing the divergence early on. So what this tells us is that there are favorable effects of prevention trials worth it to delay diabetes. As far as reduction on complications, it's going to take long-term observation to see these effects. So we look at the prevention trials, and obviously these are done in academic institutions, and I say, yes, we can prevent diabetes in academic institutions. The real question, can we now take what we learned in academic institutions and apply it to the general population? And this is the real promise of the research that each and every one of us do in our labs and in our clinics. And there's a lot of steps that were taken with prevention in this country, from the YMCA getting an innovation award from CMS, and Congress authorizing CDC to implement a national diabetes prevention program. And the results of this was published just a few years ago, suggesting that, no, you're not going to achieve the results you see in an academic world, but a 5% weight loss and about 30% was about the average in these particular studies. Now, the data from these trials, of these studies, plus others, were reviewed by CMS in 2016, and this is where they made the decision to start reimbursing diabetes prevention services for Medicare beneficiaries beginning January 1st of last year. What can be more exciting than having research done 20 years ago translated to the general population? This is the way you prevent diabetes. But now we understand, with 2 reports from last year, maybe we have more work to do, translation. In fact, there were 2 studies reported last year, one at ADA and one of the American Journal of Managed Care, suggesting that maybe the reimbursement's not adequate enough to completely cover the cost. The reimbursement depends on attendance, which may wane in the community programs. The reimbursement's based on achieving the goal, which may not be what we see in the academic setting. So maybe this needs to be reevaluated. The other concern was maybe there's not enough adequate providers. So there appears to be, at least from these early studies, some issues that we need to address with translation to move forward. But even if we address that, there's still some scientific questions. No matter what we do, we can reduce weight in individuals in these weight loss trials. But then what happens? Recidivism, weight regain. So maybe there are more scientific questions we need to ask. What is the biologic basis for weight regain? What are the molecular process, cellular process for weight maintenance? So we still have a lot to work to do as far as research to understand some basic biologic processes, but it's clear we have some work to do on the translational side as well before we can address this global epidemic. Now let's move to remission. If we're going to reduce the burden, yes, we need to prevent on a wide-scale basis. But if we're also going to address diabetes, what can we do to reverse the disorder? Meaning that, can we take individuals with type 2 and actually drop them to a non-diabetic state or subdiabetic levels for glucose control? The term is called remission, and I was again honored 10 years ago to be on this ADA committee. And we were asked a question: what is the definition of remission? What are the factors related to diabetes remission? I'll be honest, in 2009, when we began to tackle this problem, none of us thought that remission would be as common today as we thought 10 years ago. None of us thought that this would really be a common discussion among people who treat obesity or diabetes. But yet at that time, we tackled this. Okay, well, what was the term? In this consensus, we had oncologists, we had endocrinologists, we had metabolic surgeons. Was cure the right answer? Well, cure, you'll only know if you have a cure once you take it to its death and find out you didn't have the disease, and clearly not the term. Reversal, we struggled with reversal. Reversal would suggest that, yes, you completely reverse the disease and reduce the underlying pathophysiology. We didn't think that was appropriate. The correct term is remission. Remission remains today. You're in remission knowing that if that metabolic stress continues or comes back, yes, you'll revert back to the disease, but there were other factors. What are the time factors to consider for these abnormalities to be resolved? Do we accept 6 months? Do we accept 1 year? For definition, what criteria do we use? Any definition we use for remission has to be agnostic of whether we get there with surgery, pharmacotherapy, or lifestyle. And finally, the most important, is remission completely going back to non-diabetic levels? Or do we accept anything under the diagnosis of diabetes and having prediabetes, impaired fasting glucose, impaired glucose tolerance? Is that considered a remission? I ask these questions because the definition we came up with at the time was a complete remission is an A1C below at normal. A1C of 5.7%, glucose of 100 for 1 year, that's a complete remission. A partial remission is an A1C in the pre-diabetic range, 5.7 to 6.4%, a glucose 100 to 125. That was the definition we decided in 2009. Now, this decade, there's been a lot of studies that looked at diabetes remission. From 2012, 2019, these are just a few examples. I know that others in this room probably have published their remission, but I want to make a point with these studies on this slide. One thing you'll begin to appreciate, the one definition was not used by all studies. Look ahead. Looked at the ADA definition, partial versus complete for 1 year. But then we had the Swedish obesity study. That started so early, it used just a fasting glucose of 110. Well, anything below a fasting glucose of 110 can be normal, below 90. It can be below 110. It could be still be prediabetes. Others used an A1C of 6.5%. Well, 6.5% last March was where the Association of British Clinical and Diabetologists decided anything below 6.5, their position statement was that was remission for 6 months. And you can see that others looked at A1Cs of 6% or other values. So let's take a quick look at what metabolic surgery has done with remission, and we'll start with the Swedish obesity subjects. Glucose less than 110 as the definition for remission. Remission at 1 year, 72%. But when you look at 15 years, only 30% in remission. There was a waning. But still, surgery group 6 times more likely to get remission compared to the control group. We look at the study in the UK, a population-matched cohort study that looked at gastric banding, sleeve gastrectomy, gastric bypass. over 3 years, there's no question surgery an 18-fold greater likelihood of developing remission. And this study suggested that the bypass and sleeve appeared to perform better with the gastric banding, but they used an A1C of remission less than 6%. We have Matson's trial. He did something different. He used an A1C of 6.5% on no meds, or metformin, 6%. And in this Danish cohort, looking at bypass, at 2 years, a 74% remission. What was an interesting observation, of this 74%, about 25 relapsed in 5 years. But others went into remission, so that across the cohort, a 74% remission from the metabolic surgery procedure. And finally, we have the Stampede trial, Phil Shower and the Cleveland Clinic. A1C less than 6% as definition of remission, and medical therapy, gastrectomy and bypass, far greater than the medical therapy. But you're seeing the differences in percent. 29% here, 70% in others. Why? We have different populations, different durations, different comorbidities, and different definitions. So it does behoove us to come up with a single definition of remission, and from the third Diabetes Surgery Summit, we're actually working on that definition that we can all agree to in moving forward. So now let's talk about going back to children and youth and adolescents. We see the profound effect of metabolic surgery in adult diabetics. But now we talk about youth and adolescents. As you know, they didn't respond as well to adult management strategies with pharmacotherapy. But it was addressed whether metabolic surgery worked from the teen labs and the lab study looking at bypass. Diabetes remission in this study, once again, less than 6%. In this particular study, same weight loss achieved in the youth and adolescents and the teens versus the adults. The diabetes prevalence on the left here in the adults, 31% dropped to 12%, 14% dropping to 2%. But on the right, youth and adolescents, an 80% remission rate after 5 years, as opposed to 53% in youth and adolescents. So this suggested, even though youth and adolescents may not respond to medication as well, certainly in this particular study, had a greater remission or chance of remission. Now, this may be, you may say, well, the adult has had diabetes longer, there's other comorbidities, and yes, that may be the argument. But this study clearly looked, and with all factors being considered, that remission seemed to be pretty profound in this group of youth and adolescents. So, respond pretty well to metabolic surgery and teenagers. Okay, so same operation, same weight loss, but teens significantly more likely to be in diabetes remission, and for that matter, remission of hypertension. So this is remission from metabolic surgery. What about lifestyle? So we don't have many large studies looking at lifestyle and remission, but one of the largest that we can state is the Look-Ahead trial. Looked at intensive lifestyle intervention as opposed to diabetes support and education. This was not a remission study, but there was an ancillary analysis of the Look-Ahead data. And so in this particular study, looking at the ADA definition, both partial and complete, prevalence of any remission, partial, complete, 11% in any 1 year, year one. 7% of any remission in year 4, as opposed to 2%. But this is prevalence in any year. If you look at continued prevalence, prevalence greater than 1 year, 2 year, 3 year, 4 years, you can see in the look-ahead, chance of any remission was 3.4%. And if you look at complete remission, 1.3% year 1 or 0.7% in year 4. So you'd say, well, the results here are pretty sobering compared to the data we have in metabolic surgery. So this is why many of us are now looking at the direct data, a trial that was directly done in UK population, in primary care clinics to induce remission, at what they were able to achieve with their particular program. They were able to look at 150 patients with intervention and control with a program that looked at very low-calorie diets for 3 to 4 months. Now, 3 to 4 months, 600 to 800 calories a day, followed by step food reintroduction and weight maintenance. The design of this trial actually started with short-term trials of 8 weeks to counterpoint trial and 6 months to counterbalance. Now a 2-year trial in a primary care population. Again, pretty aggressive intervention as far as calorie restriction. But what this study showed is that less than 5 kilograms weight loss at 12 and 24 months, really some of the same remission rates you would see that was similar to what we saw in Look Ahead. But 5 to 10 kilograms, 29 to 33%. At 10 to 15 kilograms, 57 to 60%. And then we look at greater than 15 kilograms, greater than 70%. If we look at anything over 10 kilograms at 24 months, 64% are in remission from the weight loss from this particular study. Now, 64% is what we see in metabolic surgery. So what's common here is the sustained and dramatic weight loss in this particular study. Now, can we do this in this country? Can we do it in primary care? That's not the point. It's food for thought that is to sustain weight loss in this particular study that induced remission in these individuals with diabetes. So throughout the surgical studies, the lifestyle studies, we know that we can induce remission. And the person most likely to have reduction is early and sustained weight loss, better baseline beta cell function, and duration of diabetes. It was shown in the Look Ahead, the longer you have diabetes, the less likely you are to have remission. It was shown in the Direct trial, even though they only included patients with a duration of 6 years, there was a difference between duration of diabetes versus those who responded and those who didn't respond. And finally, the Swedish obesity study, looking at 1 to 3 year duration of greater than 4 years, and it's clear. The longer you have diabetes, the less likely you are to have remission. If anything, this speaks about having aggressive intervention early on, particularly in those with type 2. So what is the mechanism? Now, there are many hypotheses and theories put forward and actual research studies to determine what is it about the beta cell, what is it that allows individuals to respond. And there's a lot of data, and I'm just going to sum it up with Taylor and Roy Taylor's work and White's work that suggests that you start with a healthy beta cell, and with metabolic stress, obesity, inflammation, ectopic lipids, the beta cell loses its ability for specialized function to respond to glucose stimuli. And that this is reversible if that stress is removed. Now, the argument being that was put forward that if this stress continues, then the advancement of beta cell failure and you're not able to remit. Now, this may be a function of the duration of the disease, but however, we also know this may be genetically predisposed, so this is not the end-all be-all here. But again, this metabolic stress and loss of specialized function. What has been interesting is trying to tie this back to ectopic lipids. We do know the pathologic role of visceral fat. We know the pathologic role of ectopic fat in the muscle. What this group has also proposed, when you look at remission in these lifestyle studies, that perhaps we can tie it back to what we see in liver fat. Once again, there have been early studies years ago, for years, that have suggested that very low-calorie diets can reduce intrahepatic fat within weeks to months. And again, these slides are courtesy of Roy Taylor. Well, he proposed that perhaps the liver plays a role in remission in the Direct trial. And 10 years ago, what has been put forth is the twin cycle hypothesis. There are people who argue that this is not the case, others that argue, but don't shoot the messenger. But I'm going to propose what they've looked for in the Direct trial. That you start with positive caloric balance. And on the background of insulin resistance, increasing liver fat, de novo lipogenesis. And this reduces this is resistance to insulin suppression of glucose production and increases glucose output, what increases plasma insulin, which feeds back, and the vicious cycle continues. What has been proposed is then there's increased VLDL triglyceride export, which can deposit fats in other tissues, argument that it deposits fat in the eyelid, and this is going to, again, metabolic stress on the beta cell, reduce insulin response, increase postprandial glucose. And so this cycle continues, a twin cycle in the pancreas and in the liver. Again, there'll be progression of the beta cell failure. So the authors of the DIRECT trial decided that they would prove this, or try to prove this, with observations that suggest that, yes, they've shown that very low-calorie diets within 8 to 6 months can reduce hepatic fat. They've shown it in a year. And those who responded were in remission versus those who didn't. A significant reduction in liver fat, a significant reduction in pancreatic fat. But only those in the remission had a reduction in export of VLDL triglycerides from the pancreas, and only those who responded had an increase in acute and maximum insulin secretion. So reducing the metabolic stress was postulated to reverse and restore the beta cell function in this particular group. So just a simple schematic: increased liver fat, increased liver export. Their argument, increase pancreatic fat and impair the beta cell function, and this is where caloric restriction metabolic surgery can come in, reducing the metabolic stress. Again, just one hypothesis to explain the clinical outcomes. So finally, let's move on to precision medicine. There's been great interest in precision medicine for the past many years. It was heightened on January 20th, 2015, when President Obama stated in his presidential address he's launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes. And money was allocated to NIH, National Cancer Institute, FDA, to put this All of Us program together, million-patient cohort. So we look and we ask, well, what is the definition of precision medicine? Well, many people have used the definition of personalized or individualized medicine as opposed to precision. Well, individualized medicine is what we've been doing for years. If we take a patient and they'll have modifiable outcomes such as the comorbidities, the glucose control, or hypoglycemia as opposed to the age of the BMI, we would design a therapy based on those comorbidities to get an individualized plan. That may be personalized, individualized, that's not precision medicine. The NIH definition is an approach that takes into consideration genes and environment related to the patient. That definition is also endorsed by the CDC and the National Health Council. A few years ago, Paul Franks had this wonderful schematic where he looked at stratified diabetes medicine as the interaction of the exposome, all non-genetic elements which we are exposed. And this could be the family history. It can be obesity. It can be medication. It can be stress. It can be obesity, what have you. Everything in our environment. And the relationship to the human physiome, the genome, the epigenome, the transcriptome, the proteome, the metabolome. Now, this is incredibly complicated, and interaction of every environmental issue with what's going on in the body will take generations to unravel. But this one schematic is indeed the holy grail of precision medicine, understanding these interactions. So when you look at some of the factors in the exposome, for example, look at stress, and we look at disturbed sleep, and we look at coffee. And the argument would be, wow, if these factors in our environment really are going to have an effect on me achieving precision medicine personally, every one of us in this room are going to be in serious trouble. All right, so the All of Us program, about 270,000 patients entered now. I'm not going to go through all the goals. What I am going to discuss is one of the goals is to develop new disease classifications. And by that, I mean this, getting back to the heterogeneity. Let's take this first individual, 45-year-old male. He has an A1C of 7.6%, diagnosed only 4 years, BMI of 24, insulin therapy within 2 years, but yet he has cardiovascular disease and retinopathy. And then compare it, and you may see this in your clinic. The next individual comes in, has an A1C of 54, diagnosis 10 years ago, BMI 33, controlled on metformin, and no complications. But yet, both of them are classified as type 2 diabetes. Would anyone argue that these are the same disease? Would you say that, well, gee, one has genetically predisposed to develop the complications? Well, that may be true, and there are other confounders, but is this the same disease? So to understand the genesis of the classification, let's go back 80 years. And in 1939, diabetes was subdivided on oral glucose tolerance test into insulin sensitive and insulin insensitive. It was not until 1979 we got the current classification. Type 1, insulin dependent. Type 2, non-insulin dependent. 1985, the World Health Organization endorsed type 1 and type 2, insulin dependent, non-insulin dependent. But it was interesting that in the early 80s, we got the first description of a different subtype. Maturity onset diabetic young was described in the early 70s. It took 20 years before we found out the genetic underpinnings of maturity onset diabetic of the young. In the 1990s, we had the identification of another subtype, latent autoimmune diabetes in adults. And then 2007, they had the first GWAS studies in diabetes. It was interesting at that time that Science said, well, this is a breakthrough of the year. And many were writing, well, it's just going to be a matter of years before we have the genetic diagnosis of most of the cases of diabetes. But it's been many years later. Thank you. It's been many years later, and what we have today, we have 400 genetic variants associated with diabetes, but they only explain about 18% of the risk of diabetes. So even though we're making progress, the genetic variants today do not explain the majority of risk for type 2 diabetes. What is the problem in the classification of type 2 diabetes? Well, one argument is that for the past 80 years, we've only used glucose as the biomarker to classify type 1 and type 2. One biomarker. And there's a lot of interest today that let's look at some of the other factors related to diabetes and to classify diabetes in a different way. So let me share with you some data from other groups that have suggested let's look at some non-glycemic ways to look at diabetes differently. And I'm going to share with you some Leaf's group work that was published in 2018, where in Scandinavian cohorts, about 15,000, he went back and looked at these particular factors, whether you had GAD antibodies, positive or negative, age, body mass index, A1C, measured the insulin secretion and the insulin resistance, and based on those characteristics, clustered groups of patients based on these characteristics, and within these cohorts, and because there were registries and they could follow these patients, able to track what the treatment pattern was, track what the complications were. So this cluster analysis, taking type 2 diabetes, originally 85% with type 2, but cluster classification, another 5 subtypes. So he identified these subtypes as severe autoimmune. This is a subtype that was antibody positive, insulin deficient, similar to, this is a type 1 and the LADA cases. Then he had type 2, a severe insulin deficient disease, which was insulin deficient like the autoimmune, but no antibody positive, low insulin secretion, poor metabolic control, increased risk of retinopathy. He had a group that had severe insulin deficiency and high rates of nephropathy and hepatic liver disease. A fourth group that had moderate insulin resistance, but early onset, and then a moderate age-related diabetes. So he classified these and then followed them over time as far as treatment patterns and complications. Let me just give you a few examples. Comparing severe insulin-deficient diabetes with the severe autoimmune deficient diabetes. Both of them, because they were insulin deficient, had high rates of ketoacidosis, but only one had the genetic association and haplotypes associated with type 1, whereas the other had genes associated insulin secretion deficits in type 2. This particular group had the highest rates of retinopathy. So in common, they had insulin deficiency. What they didn't have in common was autoimmunity, but one had higher rates of retinopathy. As far as the severe insulin-resistant diabetes, what was important, they validated this across different cohorts. This had the highest rate of nephropathy, the highest rate of fatty liver disease, and associated with genetic variants associated with hepatosteatosis. So a lot of interest in this clustering, and a lot of interest today. This has been validated in Chinese and American cohorts. Not everyone agrees with this. John Dennis just last year suggested that clustering is not the way to go. That if you just look at the BMI and the age of the patient and look at other existing comorbidities at baseline, that he was able to show, well, I can show the same prediction. So food for thought. Not everyone agrees with this clustering, but one validation was done just this past year. And this was done by Zaharia's group in the German cohort. What was impressive about this study is he did sophisticated phenotyping. He looked at the clamp. He did the MRI of the liver, hepatic fibrosis score, and functional peripheral and autonomic neuropathy testing. He was able to confirm that there were clusters of autoimmune disease, the clustering of severe insulin-deficient diabetes, and actually showed here they did indeed have the highest rate of retinopathy, the highest rate of neuropathy. The severe insulin-resistant had the highest rate of nephropathy in the German cohort, highest rate of liver disease. The moderate obese diabetes, high insulin resistance, yet moderate control, and then we have the moderate age-related diabetes. So again, food for thought, and the point here is that using non-genetic markers to cluster those with diabetes and actually showing some promise as to their ultimate development of complications. So the approach would be simply this. We have a heterogeneous population, and diabetes is certainly heterogeneous. Compared to the control population, the approach that many were taking is let's subclassify and put in clusters of common etiology. And from that point, let's let the omics do the job. Let's see what's different about these clustering and hopefully have biomarker discovery. And in this way, pharmacogenomics can then identify the best approach. And again, this overview of precision medicine, going from identifying the disease to then characterizing the disease and coming up with the best therapy, is indeed precision medicine at its best. And once again, it's going to take years to accomplish this in diabetes. So where we are today, we still have the classification of type 1 and type 2. But hopefully you've seen today that there are common features. Type 2 has autoimmunity. Type 1, cases of obesity, which is a problem. Insulin resistance, inflammation in both. So different classifications, but there's a lot of common features of both. And only today do we have precision medicine for monogenic forms of diabetes. So the monogenic forms with MODY and neonatal diabetes, this is the poster child of precision medicine and diabetes because we have direct genetic linkages and diagnosis of these disorders. And precision medicine is where when you get a genetic diagnosis, you will change treatment. And that certainly is the case in the small percentage of cases that have MODY in this country or around the world. So yes, there is precision medicine in type 2 diabetes. Yes, it's a small percentage at this point, but we have to work moving forward, not only in our work in this generation, but it's going to take many, many years to arrive at this. So let me close. We do know that the burden of type 2 diabetes and obesity remains a challenge in our society. We know we have an incredible arsenal of medication and newer strategies at our disposal. If you're in obesity research, if you're in diabetes research today, there can be nothing more exciting today. When I started 30 years ago, we had insulin and we had sulfonylureas. And in my fellowship, when they rolled out the first glucose monitoring machine, which took 15 minutes to warm up, it took another 15 minutes to have a blood glucose, I thought it didn't get any better at that time, right? Didn't even have to go to the lab. We can get a blood glucose in clinic. What has happened over the past 30 years has just been phenomenal. What has happened in artificial pancreas development, from what's happened in the 80s, the pump, the census, the algorithms, to what we have commercially available today, has just been phenomenal. So this is an incredible era for obesity and diabetes, and it's going to continue. More deep phenotyping techniques, technological developments, computational power, statistical sophistication, the use of the big data are going to move us down the road to more precise, individualized response. So for me, I'm optimistic. I think the future will be one in which the promise of precision medicine is going to be realized. But if we take a step back and we say, well, this is fantastic, all this technology, all this big data, all the incredible response rates that we can get across cohorts, regardless, patients will remain at the center of care. And all our technology and all our research has to be translated and disseminated to the provider, because the ultimate success is going to depend on the skills of the provider. It's going to depend on what that provider knows and what we disseminate to the provider as the best care and the best strategies and the priorities of the patient. And again, the provider and the patient interacting is going to be the key. It could be the hurdle, or it could be the opportunity that we've all been seeking to address the obesity and the diabetes epidemic. So in that case, I would submit to you that regardless of the science, medicine today is an art. Medicine is an art and not a science. And this being in Vegas, I think I can carefully say that the magic, therefore, lies in the magician and not in the wand. So thank you very much, and I want to appreciate the opportunity to be here.
I want to thank Dr. Cefalu for his outstanding lecture, and I'm going to present him this plaque. Over here. Okay, where's the photographer? I think you'll agree that he's given all of us a lot to think about and many ideas for future research. Dr. Cefalu, thank you. Okay. I don't see where the photographer is. No photographer. You left this, but please enjoy the poster sessions and the coffee, and thanks very much for attending.